This lecture will cover Chapter 27, Introduction to Hematologic Neoplasms. Hematologic neoplasms result from abnormal growth of cells that are within the hematopoietic stem cell system. And they are actually an acquired genetic disease in which the patient is actually, they're not born with it, but they actually acquire it later in life. Now in 1960, Noel and Hungerford published an abstract that described a constant shortened chromosome in 7 patients with chronic myeloid leukemia, or otherwise known as CML. And this shortened chromosome was later named the Philadelphia chromosome, which was actually named after the city in which it was discovered. Hematologic malignancies result from an acquisition of one or more mutation in key genes that actually regulate cell growth, otherwise known as proliferation. They also affect their survival, the differentiation, so for the cell to determine whether or not it's going to be, whether it will mature from one particular stem cell line versus another, or it will also affect its maturation. Now, your leukemias originate in the bone marrow, so the leukemia cells will actually pass over into the peripheral blood. But they also can infiltrate the lymphoid tissue, which is going to include your spleen, your liver, your lymph nodes, as well as some of the other organs and tissues throughout the body. Lymphomas, on the other hand, are actual solid tumors within the lymphoid cells that usually will originate in the lymphatic system and then proliferate into the lymph nodes and the other lymphoid organs and tissues. You can occasionally see these circulate in the peripheral blood. The myelodysplastic syndromes were once known as your pre-leukemias, and they are acquired hematologic disorders that are characterized by a progressive cytopenia within the peripheral blood, which reflects defects in your erythroid lineage, your myeloid lineage, as well as your megakaryocytic lineage. Now, your leukemias are going to affect your lymphoid and your myeloid lineages, and they can further be broken down into acute and chronic. With your acute leukemias, this is going to affect your precursor cells. It's going to be sudden in onset with a rapid progression. It's fatal within weeks to months if it's actually left untreated. So the white blood cell count can be variable with an excess accumulation of precursor cells, or your blast of a particular lineage will be present in the bone marrow and peripheral blood due to a block in the differentiation. So there is an actual arrest in the maturation. Chronic leukemias will affect your mature cells, and so it's going to have a gradual onset with slower progression. And with patients that have a chronic form of leukemia, they're going to have a little bit of a longer survival. Now, the white blood cell count is typically going to be elevated with a proliferation and accumulation of mature or maturing cells of one particular lineage. If leukemias are left untreated, then most of the normal cells that are within the bone marrow will eventually be replaced by the leukemia cells, so it's going to actually affect your bone marrow function. With untreated acute leukemias, the rapid expansion of bone marrow blasts will actually result in bleeding due to thrombocytopenia. And so you can see things like fever that's going to be caused by neutropenia, and fatigue due to decreased hemoglobin concentrations. Now, with untreated chronic leukemias, the symptoms are usually nonspecific, and they can be very variable. Some patients will be asymptomatic, and then diagnosis just happens to come about based off some sort of incidental finding with an elevated white blood cell count or some sort of abnormal finding on the peripheral blood smear. So just a routine checkup or routine lab work can catch this occasionally. It's not unusual to have a patient come into the emergency room for a complaint of something else, some sort of pain or an injury or something, and the routine lab work is performed, and then you review the smear or run the CBC, and then you find this, and you have to pass it off to a pathologist who will in turn make the diagnosis and report that back to the physician. So just as a recap, so your leukemias are your lymphoid versus your myeloid lineage with acute versus chronic. And there's a nice chart in your book that kind of compares those and the differences between those. Your lymphomas are your solid tumors of your lymphoid cells, and your myelodysplastic syndromes will affect your erythroid, myeloid, and or your megakaryocytic maturation or your platelet maturation. The National Cancer Institute Surveillance, Epidemiology, and End Result Program estimated in 2015 approximately 1.3 million people within the U.S. to have leukemia and lymphoma. And of course, since then, I'm sure these numbers are rising very rapidly. There are certain types of leukemias that tend to be more prevalent in a particular age group. For example, your acute lymphoblastic leukemia is usually seen in just your younger children, whereas your chronic lymphocytic leukemia and your myelodysplastic syndromes are usually going to be more within your older adult population. Now, while most hematological neoplasms have an unknown cause, we have been able to attribute a few things to actually causing these mutations. So, for example, there are environmental toxins that can actually induce genetic changes that will lead to a malignant phenotype. For example, radiation exposure. You can see this in people that have been exposed through some sort of like an atomic bomb explosion. Exposure to organic solvents like benzenes. You've seen this a lot in like the automotive industry and some of those cleaning products. Those organic solvents that may be used with auto body repair work, they've been known to cause some mutations, to cause some malignancies. Some of the chelating agents and some of the chemotherapy drugs have also been known to induce DNA damage to the hematopoietic stem cells that can actually lead to a malignancy. So while you may be using it to treat one cancer, it can cause mutations and actually cause another cancer. So this has been known to happen. Viruses have actually been implicated in causing various hematological neoplasms because they do actually have the ability to insert themselves into the host genomics, and from there they can cause various genetic and epigenetic changes and produce various oncoproteins that will actually interfere with the normal cell processes that will usually actually protect the cells from forming any sort of malignant transformation. However, once these viruses kind of insert themselves into the genetic makeup and make alterations, then those cells can now lose their ability to sometimes, just depending on what that mutation is, but they can lose their ability to actually program themselves to die or implode once it recognizes that there's an abnormality there. Some of the things that you may have heard of in the past that have been linked to this would be something like HPV virus, HTLV, the human T-cell lymphotrophic virus. And so there are several different viruses out there that have actually been linked to the ability to cause some of these mutations. Another example would be Epstein-Barr virus, the virus that most of us are familiar with as far as the cause for mono. So it's actually a DNA type virus that will invade the B lymphocytes, and it's been known to be a contributing factor to Burkitt's and non-Hodgkin's lymphoma. Also, like HIV has been known to increase the risk for non-Hodgkin's lymphoma as well. And also, hereditary cancer predisposition syndromes have been linked to germline mutations in more than 60 different genes, which actually provide or initiate an increased risk of actually developing those hematological neoplasms. So this could be something like a congenital bone marrow failure syndrome. Now, over the years, there's been attempts to try to make like a universal language, so to speak, to be able to classify these different cancers. So the French American British classification was devised in the 1970s and 1980s, and it was based off of the morphological characteristics. So it relied heavily on the ability to actually examine routine histological type stains and preparations to be able to distinguish the lymphoid and the myeloid neoplasms. It was around 2001 when the WHO organization, World Health Organization, actually collaborated with the Society of Hemopathology and European Association for Hematopathology. And what they actually did is come up with the WHO classification system to classify some of these neoplasms. And so what this actually does is consider the clinical features, the morphology, immunophenotyping, cytogenetics, and molecular genetics to actually classify these various malignancies. And so it uses a broader category of matured lymphoid neoplasms, myeloid neoplasms, and acute leukemia to kind of help expand on each of those a little bit better and provide better diagnoses for these particular malignancies. Cellular processes involved in hematopoiesis and its regulation are highly complex, and the mutations can cause any sort of dysregulation in the stimulatory as well as the inhibitory pathways. Some of the types of mutations that we see are things like chromosomal rearrangement, gain and loss of chromosome, total or partial gene deletion, point mutations, insertations, and gene duplication or amplifications. In hematologic neoplasms, mutations or deletions will actually disrupt key gene coding for various cellular proteins and processes, and it can result in one or more of the following. There may be uncontrolled proliferation. This can be caused by mutations in genes that actually code for signal transduction proteins or growth factor receptors. So what will happen is there's actually nothing to stop that activation without stimulus or without the ability to suppress that response. So the cells will just keep producing, and there's nothing there really to block it. There may be loss of DNA repair, and so this can result because there's an inactivating mutation or deletion of genes that actually code for DNA repair proteins, cell cycle proteins that actually regulate the cell cycle, or the checkpoint proteins that will actually stop that cell cycle from happening when there's any sort of detection in that DNA that there's some sort of damage that has happened. So if the cell is not actually able to block itself from further developing when it detects that damage, then that cell will actually continue to progress and proliferate as an abnormal cell. There could be a block in differentiation due to mutations in the genes that code for the nuclear transcription factors or the aberrant changes in their epigenetic regulation. So in other words, their ability to progress up through the normal maturation cycle. So this will actually lead to a maturation arrest or dysplastic changes. There may also be apoptosis inhibition. So if there is a mutation or deletion of the genes that actually code for the various proteins that will cause that programmed cell death, so if those aren't there, then these cells are not blocked, and that programmed cell death does not act as it should normally. So this will actually lead to a persistence of leukemic stem cells that retain self-renewal properties. So in other words, they'll just kind of keep making themselves over and over again. So when you're in the hemopoietic environment, apoptosis is actually essential to to contain and control any sort of massive cell expansion that can occur. So when those cells are rapidly reproducing, then they're going to expand. They're going to expand pretty rapidly, so you're going to get a lot of cells produced at once. And so this usually happens during times of like stress, infection, hemolysis, hemorrhage. So if that environment is stimulated for whatever reason, the body usually will the cells can actually program itself to kind of shut down. Whereas if you have any sort of deletion in its ability to determine when it's time to shut down, then you're going to continue to have that production of those abnormal cells. Epigenetic mechanisms control how genes are expressed and silenced. They are important for normal gene expression in all types of cells and are critical for the complex processes such as the embryogenesis and cell differentiation. Now, heritable aberrant epigenetic changes can happen in the hematopoietic stem cells, and those changes are retained throughout the future generations of those cells. So as that replication continues and new cells are developed, then it's important that we actually have that normal development for those future cells. However, if there's changes that happen, then it's going to continue to happen throughout the next cells as those cells continue to divide and produce new daughter cells. Aberrant epigenetic mechanisms can initiate and maintain many various hematological neoplasms. Oncogenes are derived from normal human cellular homolegules called proto-oncogenes. So they are essential for normal cellular function, and they're very important in the signaling pathways, the cell proliferation, cell differentiation, as well as apoptosis. Now, if you have a mutation in the proto-oncogene, it can actually convert it into an oncogene with a leukemogenic type of potential. So only one mutated copy of an oncogene is required in order to contribute to a leukemogenesis. So just one abnormal cell ruins the whole batch. So it's kind of like that one bad apple ruins the whole batch kind of thing. So most of your chromosomal translocations in a leukemia is actually going to involve an oncogene. Once you get these mutations, they actually cause a continuous, unregulated activation of these oncogenes. And this is what we actually call or refer to as a gain-of-function mutation. So that mutation, once it's placed in with only one abnormal copy, then it can continue from then on to produce those abnormal cells. So that gain-of-function mutation, wonder where you've heard that before. Now, in your hematological neoplasms, the type of proto-oncogenes usually involved are going to be your signal transducers, such as your tyrosine kinase, your growth factor receptors, or your transcription factors. The tumor suppressor genes code for proteins that protect cells from malignant transformation. Normally, they will actually slow down cell division and then promote the apoptosis or programmed cell death. However, if they've actually been inactivated or deleted, then they will actually promote malignant transformations. However, this phenotype only comes malignant after both alleles are deleted or inactivated, and this is known as a loss of function mutation, so you have to have both of those to be abnormal. Now, the mechanisms for the loss of function of tumor suppressor genes are going to include the gene deletion, inactivating mutation, and epigenetic silencing. Now, if there's a mutation in the DNA repair genes, then it can actually cause a genetic instability and increase mutation rates, leading to an increased risk of malignant transformations. So just as a reminder, if there's any sort of chromosome or genetic abnormality in any of these that we've just discussed, then they're going to actually have an adverse molecular effect on the proliferation, the differentiation, maturation, survival, apoptosis, cell cycle control, and or DNA repair mechanisms, which is going to mean that there is an increased risk of some sort of malignant transformation. So there have been various treatments that have been developed over the years to help with the hematological neoplasms. And the one that we're most familiar with is going to be chemotherapy. And of course, you know, this can be given orally in the pill form, medication type form, or it can also be given via another route outside of the GI tract, like a IV or an injection. these treatments possess some sort of anti-tumor property. The actual method that the drug actually uses to work on these cells can be varying, just depending on the particular drug that is used. So it can actually affect the cell cycle. So this is going to be phase specific or phase non-specific agents. And then you can also affect the biochemical mode of action. So this will be things like your chelating agencies or your plant alkaloids that are actually gonna affect the way that's abnormal cell, the way it acts. So chemotherapy drugs are actually kind of given in 3 phases. Your first phase is going to be your induction phase, and this is going to where the medication is actually going to be given pretty rapidly to help kind of increase that tumor burden pretty quickly. And this is going to be with the hopes of achieving some sort of remission. Now there are 3 different types of remission. You have your hematological remission, when you actually see that the bone marrow and the peripheral blood will actually kind of return to what looks like a normal state. You have your cytogenetic remission, in which if you do any sort of cytogenetic testing, be a karyotyping, then it's actually going to, whatever that mutation was that you originally saw, you're not going to see it now. And then there can be molecular remission, where you actually no longer are able to detect that leukemia cell nucleic acid sequence through your molecular testing methods. So after that first phase of treatment, hopefully once you've reached a remission, then your treatment will move over to a consolidation phase. And so this is done with different chemotherapy agents that's going to kind of help reduce any other leukemic type cells that may be present that just aren't being caught, that aren't being detected by test methods. Then hopefully you're going to kind of kill off anything else that may still be there. And then you're going to move over to the maintenance phase, which is going to continue for a longer period of time, where you're actually going to use less intensive agents to actually help eradicate anything that may just kind of be lingering around. And so just so you know, most of us are very aware that any sort of a treatment with chemo is actually going to affect malignant and non-malignant cells or normal cells. Because what this does is actually targets any cell that rapidly divides and changes. So this is why we see hair cells to be affected, because they are cells that rapidly divide. And so because of this, because your normal cells can be affected, including your normal blood cells, the patients will have to be continuously monitored throughout treatment, because if for whatever reason, if the patient's not able to bounce back quick enough and those normal cells are depleted, then you wouldn't want to give a patient who's already at a critical level for platelets or hemoglobin. You don't want to continue to kill off the few normal cells that they do have left. So you would need to continuously check lab work just to make sure that there's no side effects that we need to be watching or keeping an eye on, because we might need to hold off a few treatments and help the patient out just a little bit. Radiation therapy will actually kill the cells, or those abnormal cells, by producing some unstable ions that will actually damage the DNA, and it can cause an instant or a delayed cell death. Now, toxic effects from the radiation exposure can actually happen during the start of treatment, or even a little ways into the treatment after a patient has tolerated it very well, and then all of a sudden they don't anymore. But it is usually reversible once the radiation is actually stopped. Complications are reduced through the use of combined anterior and posterior treatment ports, and the application of maximal shielding techniques that are actually going to help to prevent any sort of damage to normal cellular tissue. The hematopoietic system, gastrointestinal tract, as well as skin are most often affected during radiotherapy. Now, treatment of spinal and pelvic areas can actually suppress the marrow, which can actually cause a lowering of your blood counts, and to where it can actually reach a point of being life-threatening. So as you can suspect, the side effects caused by these various treatments can actually lead to needing to provide some supportive therapy to the patient. So there are numerous substances that are produced naturally that helps the body to actually bounce back. So these technologies some of the newer technologies have kind of piggybacked off of the fact that the body can naturally produce some things. So for an example, EPO has now been manufactured to kind of help stimulate that production, stimulate that bone marrow to start kind of producing its cells on its own. So a lot of times some of these things have been given to patients, so like recombinant forms of the granulocytic colony stimulating factors or the granulocytic macrophage colony stimulating factors. So these have kind of been developed over the years to kind of help the patient to re-stimulate them to kind of start making their own cells. Some of the newest therapies that are out there that you're probably starting to hear a little bit more about are targeted therapies. And so these act specifically on the malignant cells, leaving the normal cells untouched. There are targeted molecular therapies which actually bind and block certain proteins, inducing apoptosis or to actually block that mutation. Immunotherapy, which uses monoclonal antibodies to target specific antigen markers, which is actually going to promote the destruction, or it'll induce some sort of a toxic effect within that cell that's actually going to induce apoptosis. And then there are cellular therapies that's actually going to use a gene editing technology where the cells will be harvested and or use the patient's own cells to actually create therapies that will target the mutation but not the patient's cells. So they kind of like use the patient's cell genomic makeup to kind of alert these particular therapies to know that, hey, this cell's normal, so don't go after this cell. And of course there's still the hematopoietic stem cell transplant, and this is done by harvesting either bone marrow, peripheral blood, umbilical or embryonic stem cells to actually use for transplant. And of course these stem cells can actually come from identical twins, HLA matched identical siblings, or HLA matched unrelated donors, as well as using the patient's own bone marrow and peripheral blood stem cells to kind of harvest out those normal cells to replace those back into the body.